Hi again, everyone. Happy New Year, and thank you for joining us for our first Issues in Aging webinar of the spring semester in 2021. Today, we are going to hear about compounding risk, age, and race in COVID-19 from Karen Joynt Maddox. I'm going to go ahead and turn it over to her. We will have more info on CEUs, and then also we'll definitely be open for Q&A and questions at the end. So feel free to either drop those in the Q&A or in the chat, and we will moderate those at the end. So Karen, I'll turn it over to you.
Great, thank you so much, Natalie, and hi everyone. Hope everyone is hanging in despite the crazy events going on around the country. Today we're going to talk a little bit about sort of the intersection of a couple of distinct risk factors for COVID-19. I do not have enough talking plan to fill an hour. No one needs to hear me talk for that long. So hopefully we'll have some time at the end for questions and input and all that sort of thing. So for those of you who I haven't met, I am a cardiologist at the medical school and co-direct the Center for Health Economics and Policy at the IPH, and spend most of my time studying health policy, particularly policy that relates to older adults, like Medicare payment policy. And so I'm not an infectious diseases expert, and so I'll be looking at this from sort of a broad risk perspective, as opposed to getting into any of the nitty gritty on like surface proteins or anything like that. Okay, so let's get started. These are my disclosures. Some research support, as I said, from NHLBI and the National Institute on Aging, none related directly to COVID, so no disclosures that are relevant to this particular talk. And I did previous contract work for the government. Again, I don't think that's in conflict with anything I'll discuss here today. Okay, so what I'm going to try to go through today is pretty straightforward. What do we know about the association of age and race with outcomes in COVID-19? And then, maybe the more interesting part, what can we learn from these compounding risks about things like public health measures, prioritizing vaccines, and so forth? And that's where I think we'll have plenty of opportunity for discussion and brainstorming at the end of the talk. So let's start just by reviewing some of the data. So we know that older people are more likely to be hospitalized for COVID-19. That will come as a surprise to no one listening today. You can see here some data from the CDC, and each dotted line in a different color represents a different age group. And so you can see that through the course of the pandemic and its multiple sort of rises and falls, the curves sort of go in a similar pattern for different groups, but clearly the group with the highest hospitalization rate per 100,000 population is in the blue dotted line, which is those who are 65 years or older. Some more data looking at that, but in a slightly different manner, is to recognize that although individuals who are 65 or older account for only 10% of COVID-19 infections, they've accounted for 42.6% of hospitalizations. So on the left set of bar graphs here, you can see that the highest proportion of infections is happening in the 18 to 49-year-old group. And we can talk later about why that's the case, but many, sort of people who are out at work, at school, lots of places where transmission is happening, we've seen a huge boom in infections in this age range, particularly in later stages of the pandemic. But when you look over at the bars on the right, you can see that despite that group making up more than half of the infections, are only about a quarter of the hospitalizations. And so those who are hospitalized are disproportionately in the 65 and older group. Again, suggesting that although all of those hospitalizations in and of themselves might not have been as dangerous for that younger group, there is also transmission going on to and within the older community. We also know, of course, that a significant amount of the spread of COVID-19 for older adults has happened in long-term care facilities. And this is just a map from the New York Times, which has been collecting facility data, which is differentially reported by state and not necessarily audited or perfectly complete, but gives us a good sort of overall picture here And again, just to give you an idea of sort of the proportionality, long-term care facilities accounted for 5% of COVID-19 cases, but 38% of deaths. So a very disproportionate burden among some of our most vulnerable individuals in the country. And you can see from sort of the dots all over the map there that this was a national phenomenon. Again, given that the population is much less dense in the West, that's where the fewest outbreaks in facilities has been, but norm for population, it really has been something that has happened in long-term care facilities everywhere. Turning now a little bit to thinking about race and ethnicity as an association with incidence and outcomes of COVID-19. We know that age-adjusted COVID hospitalization rates are higher among people of color. So you can see in the leftmost bar, Hispanic or Latino, Latina, with a rate of 600 per 100,000 population, then non-Hispanic American Indian or Alaska Native, non-Hispanic Black, non-Hispanic Asian or Pacific Islander, and non-Hispanic White, with just a huge difference in population incidence. So again, these are rates per 100,000 population. This is not N overall. This is really, as a proportion of population, just really vastly higher rates in racial and ethnic minority communities. And when we put these two things together, we can see the combination of age and race being indicating particularly high-risk groups. So if we start over on the left of the slide, in the 35 to 44-year-old age group, we can see that the overall death rates are extremely low, markedly higher in Black and Hispanic or Latinx individuals, actually, if you look at the difference in 1 and 10, but still overall low rates. So as you move across the age ranges here, you can see that in every group, the racial and ethnic disparities are really quite stark. And actually, if you think about sort of the multiplier, right, 10x or 7x, maybe even higher relative disparities in some of the younger groups. But as you get out into the right side of the slide and just see the vastly higher death rates, and then the compounding risk of being both in a high-risk age group and a high-risk racial or ethnic group, you can see why we're having this discussion today, but really how these two things are additive in terms of the risk that they confer. Looking at some of our local data, and sorry, on the bottom, this should say from Matt Reedhead at the Missouri Hospital Association, who's done some terrific work locally, pulling together data around some of these issues. In the St. Louis region, you can see, again, the deaths per 100,000 population, markedly higher and highest in the Black 85 plus age group. And this may not be the numerically highest in every community because of the proportion of Black or other minority individuals in communities. But again, we're looking at this as deaths per 100,000 population. So what is the burden on the community? And you can see that the top three groups for highest death rates from COVID, at least up through May. This has changed a little bit as some of the rural areas have been harder hit by COVID, but at least in the first few months of the pandemic, just an incredible burden of COVID-19 deaths among the Black community in St. Louis in particular, and within that community among those in the oldest age group. So to think a little bit more broadly, we also know that COVID is associated with more excess deaths than those from COVID alone. So COVID in and of itself, obviously, is a dangerous and highly fatal in some groups disease. But COVID has also disrupted our medical system. We know particularly in places where the supply of medical care was really stretched thin. So you think about the early reports from China and Italy, and then closer to home, reports out of New York City early in the pandemic, that in the early days of the pandemic, where we were just not prepared, at least to the degree that we are now, there were issues with strain on the overall healthcare system. So overwhelmed emergency medical services, running out of supplies, running out of PPE, of course. And then as the pandemic has gone on, not only a strain on the medical system, but also a strain on the people who might want to use the medical system. So people may be thinking twice about coming into the emergency department with a certain symptom, even if that's something that they might otherwise seek care for. In the setting of COVID and in the setting of being worried about what one might encounter in an emergency department, we think that many people delayed or didn't at all seek care for otherwise very dangerous conditions. We also know that within nursing homes, people who might have otherwise sought care, again, given fear, might have elected to stay there. So we know this happened across the range of ages, not only in regard to COVID, but also in regard to other diseases. And you can see in the graph here, if you look at the tip top of the light blue line, that's the total number of excess deaths nationwide on that date or week. And so you can see that in the sort of mid-April range, there were on the order of 22,000 excess deaths. So the total across this time frame, again going out through end of September, is almost 300,000 excess deaths. Now, this does not obviously include the most recent surge. So these numbers will sound small to you, knowing what you know now about how much death from COVID there has been. But the estimate here for the total number of deaths above average, excluding COVID, is 100,000. So suggesting that about 2/3 of the excess deaths were from COVID and about 1/3 were from other things where we saw spikes. And so what do we know about that phenomenon? Well, we know that these deaths occurred across a range of clinical etiologies. So this is fascinating work, again, using the CDC data, demonstrating huge spikes in mortality rates per population for heart disease, diabetes, again, suggesting that people either delaying or foregoing care or perhaps seeking care, but in a stressed medical environment, had significantly worse outcomes. You can see here similar, although slightly less spike for cerebrovascular disease or stroke on the left. And then a particularly tragic one, I think, is Alzheimer's disease or dementia on the right, which is not, at least on a day-to-day basis, a fatal disease, right? It's not like a heart attack where if you don't go in that day, you could die of that heart attack. This to me is suggesting that people who might have had Alzheimer's were either suffering from loneliness or neglect, or were not seeking care for whatever other conditions might have been happening that then their death was ultimately attributed to Alzheimer's. But there's no reason that biologically a bunch of people should have died of dementia acutely. Now, if we look at these same curves, we're going to look at a few pages of these here. You can see also that these excess deaths, again, some COVID, some not, disproportionately impacted racial and ethnic minorities. So here you see the curves for the Hispanic subpopulation in the upper left, and that really tracks the shape of the prior curve. The American Indian, Alaska Native, or Native American, you can see a sort of different shape of the curve, that they weren't affected by the early pandemic, but that it has been, it grew in the community over the course of the summer. And then Asian non-Hispanic, Black non-Hispanic, again, a high early peak, and then white and other. And you see really the white group, while it has, I guess, the same shape in terms of sort of a little bump in the beginning and a little bump later, really very, these all have the same y-axis. So a just markedly lower burden of overall excess death during COVID, both COVID and otherwise. We also know this happened across a wide range of age groups. And so we've been talking about older adults because their absolute rates of death and events are so much higher. It is actually interesting to see that the proportional impact of COVID on overall COVID and non-COVID related deaths was pretty similar, actually, once you make it up into the 45 to 64 age group. And actually, even in the 25 to 44, there was excess death, though it happened a little bit, it's happened a little later without as much of a dip, probably because of sort of the changing demographics of the epidemic. But in the upper left panel, that's the under 25 group. And there's really, essentially no departure from normal in terms of excess death, maybe a little bit in sort of June and July. but overall really minimal compared to the other groups. Whereas the 25 to 44, which as I said, goes up and plateaus a bit, the 45 to 64, 65 to 74, 75 to 84, and then the over 85, all see a really big spike and then a dip and then another bump as we went into the second sort of surge of the pandemic. So probably none of that came as a surprise, right? These patterns, these inequities, these differences, these disparities, depending on sort of what we're talking about, they've been widely reported, they've been consistent, and they really haven't markedly improved over the course of the pandemic, with the exception of a bit of a shift in the racial differences given the rural and urban distribution of COVID. So I think the question to move into next is to think a little bit about why we see these patterns. And what do we know from the data thus far? What would we still like to know? How can we figure out why this happened, and what might it mean for things that we could do over the next couple months, or certainly in the face of a pandemic in the future? So here are some potential ways that, that COVID could be related to individual or community risk factors. And so we can think about this sort of in two buckets, right? We can think about risk factors that influence who gets COVID in the first place. And then we can think about risk factors that influence who has poor outcomes among those who get it. So those are two sort of separate, not totally separate, but sort of separate concepts. And I think it's useful to think about those because the sort of way that we'd mitigate them is a bit different. So we have sort of in the upper left, top and left, risk factors for acquiring COVID. And then in the bottom right, risk factors that we might think of for poor outcomes. And so we're just going to sort of go through these. This is not an exhaustive list. This is sort of a list of possibilities and meant to cover what I think is a wide range of possibilities, all of which contribute. There is no one answer here. So we will sort of go through each of these, talk about where there are data, where there are not data, and what it might tell us about what to do next. So if we think about risk factors for acquiring the disease, so who gets COVID, things like living circumstances, so congregate living, as we mentioned. You're around a lot of other people. If there's a case in a congregate living situation, it tends to spread more quickly. We could think about population density more broadly than that. So not in a congregate living sense, but in a, do you live in a city or a town, or within a city, how dense is your neighborhood? We could think about occupational exposure. Beyond occupational exposure, we could think about your ability to shelter at home versus continuing to work, which is not just what you do, but whether or not you're considered essential and whether or not there's supports in place to make that feasible. And then of course, individual choices, which I'll say are extremely difficult to measure. So we don't have terrific data on this in real time, but I'll go through the others. So in terms of congregate living, and particularly relevant to this group, we know that a large share of nursing homes, nursing facilities were unprepared for COVID-19. The nursing home industry, I'm sure there are many people present on this webinar who know a lot more about this than I do. But unlike the hospital industry, which is concentrated in a fairly small number of facilities with a fairly rigorous set of requirements and audits and all those sorts of things, the nursing home community is much more decentralized. It has consolidated over time. Certainly there are big sort of corporations buying up nursing homes, and it is getting more and more corporate and more consolidated. But there is still a vast range of capacity, of size, of infrastructure, of money within the nursing home industry. We're talking about places that might be in sort of a home-like setting that have a few people, all the way up to chains with hundreds and hundreds of beds. But one thing that is common across the US is a very high proportion of nursing homes having deficiencies that could be related to spread of infection. So a lack of proper infection control practices. As you can imagine, the need for some of this stuff was laid bare when COVID hit. But these are deficiencies measured prior. So things where nursing homes may not have been prepared. Now, no one went in and asked, are you prepared for COVID 6 months before COVID hit? So, but what nursing homes are asked are questions around sort of general infection prevention practices. They have other ways people can file complaints. There are sort of a set of other regulations that go into nursing home monitoring. But this study suggested that there were just across the country with an average of 40%, that nursing homes had documented deficiencies that could be related to susceptibility to spread of COVID. And thinking about compounding risk, we know that outbreaks in nursing homes were worse as a proportion of residents affected in those facilities with higher share of Black or Hispanic residents. Now, these are categorized, the top bar is by high or low share of Black residents. In this case, high means over 20%. The next is high or low share of Hispanic residents, again, with high or low being over 20%. And then on the bottom, high share of white residents is being over 80%, so sort of the inverse. And you can see that among facilities with a high share of Black or Hispanic residents, there was a higher rate of confirmed or suspected cases as a share of the bed, so sort of the spread within a facility, compared to those where there was a high share of white residents. Now, population density, while it probably matters, is somewhat less of a factor, and it's gotten even more confusing to sort of study this as the pandemic has spread into more rural areas. Certainly, it didn't start there. So initially, there was a stronger connection between population density and COVID outcomes because there was no COVID in rural areas early in the pandemic, and that has obviously changed quite a bit. But these are some data from St. Louis. This is the citation that should have been on the other chart from Matt Reed had in the Missouri Hospital Association. And you can see here, this is kind of a neat graph. The size of each bubble represents the population density within a zip code. So the biggest bubbles are the most dense, and the smallest bubbles are the least dense. And so on the y-axis, we're looking at cases per 100,000. And on the x-axis, we're looking at percent Black or African American. So there's basically three variables on this chart. There's percent Black, cases per 100,000, and population density. So you can see just off the bat that there's a strong relationship between percent Black and confirmed COVID cases. So that's moving from left to right and seeing that on the, as you move farther out toward a higher proportion Black, you have a significantly higher cases per 100,000, which we know is the case in St. Louis. Again, particularly earlier in the pandemic. Within St. Louis, so this is just looking at our local zip codes, there was not a strong relationship between population density and COVID incidence. So the red bubble up at the top there is the Ville, with just 95% Black or African American, has essentially an identical population density to Maplewood, which is the blue bubble in the bottom left, and had 10x, over 10x, the COVID cases per 100,000 in the first few months of the pandemic. So at least locally, we saw much more relationship of the outbreak to race, ethnicity than we did to population density. Again, as I have said, this is playing out differently across the country as time goes on, but certainly that was not the primary explainer for the racial differences in COVID. I mentioned occupational exposure. This is something that certainly applies more to that younger group, in which we know that there were a lot of cases and maybe not the severity of outcomes, but also to older adults who are still in the workforce. And so you can see on the left, the Black workers share in the industry, and on the right, female workers share in the industry. So if we go down the panel of graphs about Black workers first, you can see that Black individuals make up about 12% of all workers, but they make up more like 17% of what we consider frontline workers. And when we break that down even more, the overrepresentation of Black workers in the industry is a tiny bit in building and cleaning services workers, a little more on grocery, convenience, and drugstore workers. When you get into healthcare, trucking, warehouse, and postal service, childcare and social services, and then particularly public transit, you're at almost double sort of population and working population representation in those groups. So suggesting that Black workers are more likely to be in these sort of frontline essential positions that have put them at risk for exposure, particularly in the context of having inadequate PPE in so many places across the early days of the pandemic and even now. On the right bar, and I know that this talk isn't about gender per se, but I think this is interesting when you think about particularly some of the stories we've seen recently about where job losses have been concentrated in Black women, that we see how this intersects with gender. So you can see female workers' share in the industry overall is just under 50%, but as a proportion of frontline workers is over 60%. So even right there, significant overrepresentation of women in frontline positions. And you can see different patterns than looking at Black workers' share in the industry. So building, cleaning services, grocery, convenience, and drugstore, a little bit overrepresented, hugely overrepresented in healthcare workers at nearly 80% women, and childcare and social services workers at like 84, 85% women. So real differences in where exposure could have happened. And again, thinking about intersectionality, sort of, Black women being in a particularly vulnerable population during the pandemic as a result of occupational exposure. Now, measuring behavior and sheltering at home and sort of decision-making is very difficult because there are many reasons that someone could not stay home during a pandemic. Someone could not stay home because they don't take the pandemic seriously and want to go out bar hopping. Someone could also not stay home during the pandemic because they are an aide at a nursing home and there's no one to take care of the patients if you stay home. So that's one reason that it's very difficult to sort of sort out behavior when behavior is so intimately coupled with what your responsibilities are outside the home. When you think about working parents, single parent households, limited income, in plenty of scenarios where staying home was just not feasible, even if people had wanted to. And then of course, people making individual decisions on top of that, that have been widely variant, but again, very difficult to measure. So these are some neat data from Kai Tram and Elvin Gang's group, looking at the proportion of devices that were at home in St. Louis City and County by zip code from February to April of 2020. So if you look at the panel on the left, you can see that the red line represents the county and the blue line represents the city. So at baseline, fewer county cell phones were home all day than city cell phones. So more people working outside the home, with about, 20% roughly at the sort of the lowest right before the pandemic. And then you see over the course of March, when the stay-at-home order came into place, that the proportion of cell phones staying home went up in both the city and the county, and that the county ended up with more people staying home than the city, suggesting a lower proportion of what we think of as sort of frontline or essential workers and people who could stay home. And so you can see over on the right then a number of association plots between various geographic and socioeconomic factors at the zip code level and looking at the relationship with staying at home. And these are sort of hard to see, but for example, in the upper right, percent with high school diploma. So the higher the education, the more likely people were to be able to stay home. Below that, percent of families below poverty. So the higher proportion of families below poverty, the fewer that were able to stay home. So again, sort of these intersecting risks leading to differences in exposure. So to move a little bit then into the other chunk, I guess, of risk factors that we talked about, which should be risk factors for poor outcomes conditional on having the disease. So if you get COVID, what makes you more or less likely to do poorly, to be hospitalized, to need mechanical ventilation, or ultimately to die? And so I've broken these into sort of three buckets, and we'll talk about each. Comorbid conditions, which is sort of an obvious one. Prevalence of and access to testing and treatment, which gets a little more complex. And then issues around racism and ageism, which become both complex and difficult to measure. And we'll talk about all three of these in turn. So we know that people of color and older people were at higher risk of severe illness relative to younger white people, even before the pandemic. And that's because of the sort of disproportionate burden of chronic disease that makes people susceptible to bad outcomes with COVID, things like high blood pressure, diabetes, obesity, heart disease, lung disease, any of these things that put people at risk. So obviously, as you move from, this only goes up through age 64, but as you move from age 18 to age 64, sort of from left to right across the graphs there, the proportion of people who have one or more than one risk factor, medical risk factor, goes up. Of course it does. People get older, you tend to have more chronic disease. But within each of those age brackets, you can see pretty big differences between the proportion of, I should have labeled these, but white, Hispanic, Black, American Indian, Alaska Native or Native American, and then Asian individuals in terms of the preponderance of those risk factors. So the highest risk groups, even just measuring comorbidities prior to the pandemic, are minority adults. And these patterns continue on into the older age groups as well, though this focused on a younger cohort. And when we think about access to care, it matters because of what you do if you have symptoms, or if you don't have symptoms, but someone near you had the disease or whatever. Having access to care is the entry point, right? To be able to get tested, to get treated, to be monitored, to make sure that you are being taken care of if you're sick. And so we know from, these are data from 2018, they have not changed. They changed a little bit over time with insurance expansion under the Affordable Care Act, but these patterns have not changed appreciably over time, which is to say that insurance rates are lower for Native American, Black, and Hispanic or Latinx individuals. Sorry, I got distracted by the chat, which I'll look at later. And you can see that the uninsured rate, and this is post ACA. This is, as I said, this is, I believe, 2017 data published in 2018. The proportion of people who have insurance is markedly different by race and ethnicity. Now, this is not necessarily true by age. We know that those who are over 65 are by and large covered by Medicare, though that's not true for all immigrant populations, certainly. But the rates of uninsurance are much, much lower in older individuals. But even there, some racial and ethnic disparity in insurance persists. We also know that these same groups are likely to face other barriers to healthcare access. So not just insurance, but also not seeing a doctor due to cost, delaying care due to other reasons, be it availability of time off work, transportation, whatever it might be. And then having a usual source of care when sick other than the emergency room, in which you could go to a primary care or whoever, essentially. And you can see that for each of these, racial and ethnic minority populations just face significantly higher levels of these barriers. And as you can imagine, if you have symptoms, if you then need to seek care, you're much more likely to do so if you're not worried about what that's going to cost, if you know who to call, if you have a relationship with a provider, all of these things that are so crucial to making sure that people get checked out for things like COVID, treated if necessary, and monitored if necessary. It's a setup for bad outcomes for this disease, just like we see for essentially all other chronic diseases across racial and ethnic minority groups. Now, as I mentioned earlier, we also know that people may be delaying or avoiding crucial medical care, and these are data from BJC. So these are our own, these are our patients. This is across the BJC system, so not just BJH, but also all of our other hospitals, so urban and rural. And you can see the blue dots are the weekly non-COVID emergency department visits. So obviously there were no COVID emergency department visits for much of this. But you can see as of the stay-at-home order is where this sort of gray bar starts on the right. And you can see that the number of emergency department visits across the system dropped from an average of just over 10,000 down to about 5,000. So about half of our normal ER volume, and then slowly rebounded, though even in more recent data, it has not gotten all the way back up to its pre-pandemic levels. The red dots are the non-home time, a similar sort of metric as I showed you on that other presentation about people staying home, and tracks that quite well. Now, you might question then, do we see differences here by age or by race and ethnicity that might explain some of the differences in outcomes? And we really don't, actually. So we did find, when we looked across a range of visit classifications, so emergency department needed, not preventable, so things like strokes and heart attacks. Emergency department needed, preventable, things like severe heart failure or COPD exacerbations. Primary care, treatable, so milder things like a urinary tract infection. Non-emergent, so rashes, med refills. Psychiatric, and then alcohol or drug related. That in all of the medical categories, the Medicare population, so typically the older population, had the smallest decrease in emergency department visits at about, between 30 and 40% overall, compared to the other groups where there was more. There's a number of reasons this may be the case, but we certainly didn't see that older adults were avoiding the emergency department more than younger ones. We saw the opposite. And we found no differences in these decreases by race. So the BJC population doesn't have enough individuals of non-Black, non-white ethnicity or race to sort of define those other groups with any fidelity at all. But looking at Black and white, there's really no difference across any of these categories of visit in terms of the proportion drop off by race. Now, interestingly, as an aside, one would hope that the drop off in the leftmost category, the heart attacks and strokes, would have been 0. And the drop off in the right, the non-emergent group would have been like 100%, right? That everyone would have kept coming in for their heart attacks and strokes and not kept coming in for their rashes. And that didn't happen. There's a relationship here. People deferred less of the emergent care, but really not as strong as we'd like. So a lot to discuss there, but we did not see any major difference by age or by race that would explain the differential poor outcomes, at least in our system. Now, one reason that that older adults may have continued coming to the emergency department, to some degree racial and ethnic minorities, is because older adults and people of color had reportedly felt unready for telemedicine. So this was a study essentially asking people if they felt ready to engage in telemedical care, telemedicine. And among the 65 to 74-year-olds, only 25% felt unready, whereas among the 85 plus, 72% felt unready to engage in telemedicine. And then really big differences by race and ethnicity. So 32% among white individuals, 60% among Black, and 71% among Hispanic, reporting that they felt unready for telemedicine. So some of the unmet need that may explain some of the poor outcomes might not be in who chose to come to the emergency department, but in who had an sort of an alternative way to access care that wasn't the emergency department or wasn't an in-person visit. So we don't have access to, or we haven't looked, we may have access, I suppose, to how those telemedicine visits played out in our system at the same time as those other data I showed you, but it's sort of an intriguing idea about what sorts of options people have for care. And we also know, this is from a different health system, that consequently, so presumably as a result of that lack of readiness or comfort with telemedicine, that in the COVID era, or sort of post-telemedicine implementation, which in this case is COVID related, the proportion of visits for those at risk for limited digital literacy or access has decreased. So the proportion of people who are over 65, non-English language preference, Medicare and Medicaid has dropped off by quite a bit, suggesting that these are the groups that are not having any access at all now, because they're avoiding the emergency department to some degree and then not included in this sort of telemedicine shift that we've seen. I think this is a really important area to think about going forward in terms of lessons we can learn from this pandemic. And then finally, another clear reason for worse outcomes among racial and ethnic minorities and older people during the pandemic are racism and ageism. And these are harder to measure, they're harder to define, but they're crucial to talk about. And so I'll throw out a few sort of ways these might manifest, recognizing that I don't have numbers to go with these like I do for some of the other ones, but certainly individuals face different isms. And in this case, we'll sort of focus on racism and ageism when seeking care. There may be less prompt attention to symptoms. I think we've all seen coverage at the national level about, for example, Black women being ignored during pregnancy with various symptoms. Certainly we know that in older adults, it can be difficult sometimes to sort out normal from non-normal in terms of some symptoms of aging and the beginning of disease. And so that can be tricky there too. We know that racial and ethnic minorities have lower access to use of experimental treatments, some because of a lack of offering them from clinicians, some because of historical maltreatment by the medical profession, leading to less uptake within racial and ethnic minority groups. And we know that there's been talk of rationing of care. And when that's done by medical risk, given that we know that racial and ethnic minorities are at higher risk, that could get us into some very difficult discussions and decisions and things in which naming racism and ageism are crucial to thinking about how those decisions are made. There are also institutional issues at hand, so not just the individual decision-making, but norms within the medical profession, false beliefs or power structures that inhibit change that lead to sort of the unconscious mistreatment of people who are racial and ethnic minorities or people who are older, that also are extremely difficult to measure, but almost certainly contribute to the differential outcomes that we see. And then finally, the broader decisions and policies around housing, education, that have created disproportionate wealth, that have created a dysfunctional education system, a dysfunctional criminal justice system, all of those things that contribute to all of the things that we talked about, the prevalence of chronic conditions, the lack of access to care. These are not sort of accidental things that someone is born with, right? These are things that are part of a structure that we live within. And so each of these things contributes to why we see the disparities that we do. So to try to turn this into something constructive, right? What can we learn from this now that we have sort of documented many of the inequities that we see around us? And I think there are both short-term and long-term strategies. And I've thrown some out, but would very much look forward to other people's thoughts, because I have in no way cornered the market on ideas or on how we could do things better than they were done under this pandemic, not to make light of that. Short term. So some obvious things, PPE and other supplies and support for congregate living. And obviously that is first and foremost skilled nursing and assisted living, where we know that the death rates have been strikingly high, but also shelters, jails, prisons, universities, places where people are together, living together. And we could have from the beginning had a much better approach, a coordinated approach to making sure that places were supported and prioritized, where people were living in close proximity to one another. We have needed all along better outreach to older adults living at home. So not only those who are in a skilled nursing or assisted living scenario, but people who are living at home are at equally high risk. And I worry a lot about the effects of isolation, of people who have essentially just stayed home, right? Older adults who no longer have access to any of the sort of sustaining social interactions because of fear of getting COVID and of having bad outcomes, because that is a real risk. It's not clear who should do this, right? Friends and family, of course, but what role do primary care groups have in knowing who their vulnerable populations are, or elder services, or states, hospital systems, right? What role should everyone have been playing all along in sort of proactive outreach to older adults at home to make sure that people were okay? We need aggressive vaccination campaigns. And we'll talk a little bit about this on the next slide as well. But currently the congregate living scenario is covered to some degree, not all of the congregate living sites, but there has been a plan through Walgreens and CVS, for example, to get COVID vaccines to assisted living facilities, nursing homes, long-term care facilities, but there's nothing for the general older public. So there are plenty of people, the majority of older people, in fact, around the country who have no idea where their vaccines are going to come from, how they're going to get them, how that's allocated, or what to do. And as we were discussing before the webinar started, there was a thing on Twitter I saw this morning about the form in New York City for people who are senior citizens in New York City have to fill out an online form with 51 questions and requiring uploading documents to verify their identity in order to get a vaccine. I mean, that's insane. And so I think thinking very differently about our strategy around older adults is necessary. Also targeted messaging sensitive to the needs of older adults, as I mentioned, but also minority adults and people for whom English is not their preferred language. I know there's some great work going on with that at Casa de Salud and other groups around St. Louis to make sure that some of the information is communicated in a way that's culturally appropriate and that that reaches people, which is the most important thing. And in the long term, these are sort of just extensions of what I said on the last slide, which is things like public health emergency plans for congregate living. Like, these are the most vulnerable groups in the country. There is no reason we should leave this to chance. It shouldn't have been left to chance before. Certainly does not need to be left to chance again. And so we need, I think, as we, knock on wood, get this current pandemic under control, as we look toward rebuilding our public health infrastructure around future threats, one of the areas of focus for a task force needs to be thinking about these vulnerable groups. I think, we should think about sort of as we move toward things in our healthcare system, medical homes, belonging, like, we need a shift in how we think about care, right? It matters for health and well-being. It should monitor and incorporate mental health. The fact that people were really just left on their own in this public health crisis is, I think, is pretty inexcusable. And that's a societal failure, not an individual failure, but it is to say that as sort of the communities have eroded, as people have moved into bigger places and, there's fewer people who are associated with churches and sort of all those things, there's not necessarily been a stand-in to connect with people. And I think that's been exposed in this pandemic as something that for older adults within minority communities, plenty of places that there is a real need for finding ways to sort of forge those connections. We also obviously need better vaccination implementation. And I mentioned this, we had plenty of time to plan for this. We cannot let perfect be the enemy of good enough to slow the pandemic. We need shots in arms. And so this sort of like, fill out a 51 question form so you can figure out if you're in line at, position number 747 or 750 is absurd. And instead we should have, the National Guard in tents giving vaccines to every older person who's interested and then working on down the line. I think this is just a gross national failure right now. And while there's lots of ways to think about how to do it better around the edges, even our basic plan for vaccine implementation is not working. So I hope that over the coming months that changes quite a bit too, because I think it's going to harm our most vulnerable groups the most that we have not adequately planned. So in conclusion, the compounding risks of age and race have created tragic consequences for older and minority people. And I don't think I'm overstating by saying tragic. The causes are many and the failures are many, but I think trying to put an optimistic spin on this, and because I do think we will learn, the solutions are also many, right? There are things that have been exposed that we now have an opportunity to correct. And I hope that we as a society and as a healthcare system and as all of those groups sort of take that moment. So maybe this is a time where we take what we've learned in terms of creative solutions and try to turn it into a better path forward for this pandemic and for any remaining ones, of which there will be some, I'm sure. As I said, I'm not an infectious disease expert. I have not cornered the market on ideas. So I think this is a time for everyone to contribute from what they know about the world, from their research, from their personal life, whatever it is, to think about ways we could do all of this better. And I look forward to hearing from you all with our time that's left. And I will, let's see if I can stop sharing here. And then Natalie, you can tell me how you'd like me to handle questions.
Yeah, of course. I think there were a couple in the chat, which, there we go. My chat had disappeared. So first, let's do this one first. The one, let's see. Please discuss obesity and its metabolic consequences. Examples: promotes pro-inflammatory type 1, macrophages. 2, level of use between groups of OCT generics, such as vitamin D, and so on. And the use of simple CO2 monitors to check for air circulation. I don't know if you can address any of those things.
I can try. I sort of know just enough to be dangerous on some of those things, so why not? So in terms of obesity, I will take that one and then add a few jumping off points, which is to say that yes, there are clear metabolic consequences of obesity that sort of down-regulate important parts of the immune system. It's one of the theories behind why obesity is associated with higher rates of cancer, because it's sort of a pro-inflammatory state and a lack of adequate immune response for sort of general surveillance. And that would apply to infectious things like COVID as well. So it's absolutely right. I think to add to that, there is an emerging literature, not from COVID, but from the cardiovascular literature around the long-term effects of discrimination and racism and stress that also suggests that those factors can cause similar disarray. So can cause high levels of inflammation, can cause poor sort of immune response to various things. And so if you think about the, again, compounding of sort of health risks between race and age and obesity and racism and all of these things, you can imagine that there are groups that have multiple reasons to be sort of immunologically at risk. That almost certainly explains some of the differences in disease. That's a great point. I will add a slide on that actually, because that's really interesting. The over-the-counter stuff, I don't know. I believe there was a study on vitamin D suggesting that it didn't do anything, though. There are many studies on vitamin D out there, and I don't know about the other ones. I think there is some data on zinc. I don't know that there's any in COVID. That's the only one I know about. You would certainly be welcome to educate me on that one. And then the CO2 monitors, I don't know the answer to the simple ones. I do know that there have been good studies showing that the level of air circulation makes a big difference for transmission. And I don't know whether a CO2 monitor would sort of have I don't know exactly how you'd set the appropriate level or anything like that, but there had already been a fairly sophisticated set of work around sort of the intersection between environment and building and health, right? So around, you know, all this, I'm just sort of going through my knowledge here. We think about things like climate change, and we think about things like zoonotic infections, that there are many things that we could change around our buildings where we live, where we work, that could make things safer. And so there has been, I think, some very interesting work around how air quality, air circulation, and those sorts of things can really help. The pulse oximeter, I think, is a very useful tool. And that's been a way that BJC, for example, has done a remote monitoring program where people who come to the emergency department who are not quite sick enough to warrant being in the hospital, or who maybe don't want to be in the hospital but need to be monitored, can be monitored with home pulse ox and then check-ins either via an app or a phone call. And that's, I think, been an effective way to make sure that that we're keeping an eye on people and bringing them back in if they get sicker.
Okay, great. And then we had another one about if looking at demographics on immigrant and refugee populations in St. Louis, and I think specifically to COVID-19, then also where, based on the current data, where it's heading or has been heading, if that makes sense.
Yeah, it's a great question. I think it is one of the trickiest groups to study for many reasons, as you can imagine, right? Particularly with some of the, what's it called, the public charge regulation from the federal government. There has been a very understandable concern about reaching out for medical care, for any other kind of services among people who are perhaps undocumented, or among the refugee population, among people who are documented, just in general, around what it might mean to sort of receive public assistance in terms of possibility of citizenship and green cards, all those sorts of things. I'm not an expert in this area. Kim Seelinger and other people in her center, I'm sure, would have a lot to say about this. So I think it's extremely important. I would say, from my perusal into the literature around the different racial and ethnic groups, it's really poorly studied because the data are so difficult to get. So we know at the county level and at the zip code level, I don't think census block, although I could be misremembering the data, there's definitely an association between proportion foreign born and risks of COVID. But drilling down on exactly what that means at the person level has been tricky because of limitations in the data that are related to people's very reasonable fears of having data collected. So it's a great question.
Great, thank you.
Oh, Fauci recommends vitamin D. Okay, I take it back. I know if you're vitamin D deficient, that's bad. That's been proven time and again. Whether or not vitamin D supplementation helps some people who are not vitamin D deficient for most things is a little bit less clear, certainly in cardiovascular disease and those sorts of things. But it is also very low risk to take. So if Dr. Fauci says take vitamin D, I am all for it. And stand outside when you can.